We all know that the conventional risk factors like diabetes, lipids, hypertension, thrombosis are very important and we are to control them. Newer risk factors like behavioral, inflammatory theory for cardiovascular disease, demographic, genetic theories are now gaining ground, and we know more and more that our genetics, behavioral, inflammatory processes are affecting atherosclerosis. We know that cardiovascular disease is the #1 leading cause of death globally, 31% mortality. Even in India, 28% of the mortality is because of cardiovascular disease. And of these, at least 12 to 16% of coronary artery disease is affecting young people, particularly in our country. Less than 40 years, we see patients all the time, young people with severe heart disease. And so, as we see from this pie chart, that at least 2 or more risk factors are seen in 38%. But the surprising thing is that in the rest 62%, in around 20% there are no risk factors, and around 43% there is only one risk factor. Then how do we say that these people are getting coronary artery disease? And even the lipid profile has only mildly deranged or even normal in most of these 60% of the patients. And on basis of this, one of the theories for cardiovascular disease is inflammatory theory for cardiovascular disease. Inflammatory theory for cardiovascular disease is not new. Even around 10 or 15 years ago, a group from United Kingdom, I remember in CSI they presented the data, and they said that the progression and sustenance of atherosclerosis because of chronic inflammation. And they tried to give antibiotics, levofloxacin as well as roxithromycin, but they could not find that giving these drugs could retard the process of atherosclerosis. However, we know that hsCRP is important biomarker for inflammation and independent prognostic factor and a predictor of coronary events. And when we combine this with Framingham 10-year risk, as we see that as the risk increases in the Framingham risk score from 1% to 4% to 9%, 20%, at all these levels, you can see when the hsCRP increases with the light colored bar, the risk is highest. When we compare it with the LDL level, again, when the hsCRP is combined with the highest LDL level, the higher the hsCRP, the risk is highest. So, there is some sort of inflammation going on, because C-reactive protein is a marker for inflammation. This hsCRP, the concept has changed over a period of time. In 2003, they said that hsCRP will help direct further evaluation and primary prevention of cardiovascular disease. But however, they said that the entire adult population should not be screened for hsCRP and only selected patients should be assessed. After 7 years in 2010, they said that hsCRP should be measured in healthy people, and this will identify the cardiovascular risk. In 2013, they say that use of hsCRP is very useful for stratifying the high-risk patient for atherosclerotic heart disease who is going to develop coronary events. So we have seen that from 2003 to 2013, the hsCRP has assumed much greater significance. Now, atherosclerosis, we all know that from the vessel wall, the monocytes cross the endothelium and enter the adventitia or the vessel wall of the coronary artery. LDL also crosses the junction of the endothelial cells and enters the adventitia. LDL is oxidized, and this oxidized LDL is a trigger for inflammation. And this trigger for inflammation, NF-κ beta and PPR gamma is activated, and this monocyte is converted into a macrophage and the dendritic cell. And this activates two pathways, the NF-κ beta pathway and the chinurin pathway. And this further activates the platelets the activates the interleukin and the TNF alpha as well as the adhesion molecules. And this you can see that the kynurenine pathway further forms the 3-hydroxyalpha-malinic acid, and this is a normal defense mechanism against inflammation.